So thank you everybody for inviting me. As I said, I'm Billy White. I'm one of the consultants at UCLH, and I'm developed an interest in type 2 diabetes, partly because I was interested in diabetes, and then I did a PhD in obesity management, and I realized there's this massive overlap in type 2 diabetes. And also my other background is an interest in adolescent health and supporting adolescents with complex needs. And our population with type 2 diabetes definitely have complex needs. So this is sort of middle of these three triangles. So let's go. So my disclosure, like the most recent series of The Crown, the majority is based in truth. I've occasionally kind of filled out the stories a bit to combine other patients into one, so I can share some more stories and some more anecdotes. Because I think as clinicians, although it's very useful to have the headline results from a New England Journal of Medicine, there's lots of other, we need to share experiences about managing patients and tricks we learned along the way. And I'll be sharing some of those nuggets that I hope will be helpful to you. So what are the challenges now? I think there's lots of new diagnoses of type 2 recently. I suspect there's lots which haven't been diagnosed as well, but there is definitely a big pressure. On the whole, we're getting very good at managing type 1 diabetes, but type 2 diabetes is more of a challenge, partly because a lot of treatments aren't licensed for children and young people. But also these are complex families that often have multi-generational problems, a lot of sickness in the family, come from more deprived populations who are working multiple jobs or no jobs on night shifts. So they're a challenging population to support. Plus, on top of this, we've had COVID over the last year. We locked away our grannies a year ago, and there they were waving at us through the window. And a year later, we're all bigger than we were, slightly stir crazy, wanting our old lives to be back. So it's definitely been a challenging year for nearly everyone. Maybe not for Jeff Bezos and a few other people who've made lots of money this year, but for the majority of us, I think it's been a really challenging year. And I'm going to talk about two patients. So we've had, in the last couple of weeks, we've had on successive Wednesdays, we had two young females come in with new type 2. So the first one was AD. She was 14. Weight is 113 kilos, BMI 38. She had a few weeks of polyuria and polydipsia, and came in and was found to have an HbA1c of 8.9. And then a week later, 17-year-old SM came in, weight of 136 kilos, BMI 48, and her HbA1c was 12, and she had a similar symptoms of polyuria and polydipsia. And her mum had also had recently diagnosed with type 2 diabetes. Obviously, there's a whole question, is this type 1, is this type 2? And I'm not going to go into that because I don't think that's what you really want. From the title of the presentation, I don't think that's what you wanted from me. But that's a whole separate story that we can go into another day if that's helpful. But to cut a long story short with these two is we decided they both had type 2 diabetes, including having negative antibodies, a decent amount of urine C-peptide, and a examination and everything that was very much pointing towards type 2. So we've decided they've got type 2 diabetes. And what's interesting is when we breaking bad news, I think on the whole, we're used to breaking bad news about type 1 diabetes. And, for nearly all families, it's a shock. It's a massive, just they can't quite get their head around how they're going to deal with it. And, you get a pretty more uniform response to breaking bad news for type 1 diabetes. What I find really interesting about type 2 diabetes is the range of responses you get when you tell people they've got type 2 diabetes, including some families just like, oh, well, we've all got it. I guess that's normal. It was bound to happen at some point. We're not that shocked. It's not really motivating them into changing anything. Others, it's this utterly catastrophic diagnosis, particularly for some South Asian populations. It's seen as a real stigma to have type 2 diabetes, and it's a real blow to the family, particularly arranging a good marriage. And we often find that acknowledging that the young person even has type 2 diabetes or being able to work with them is a real challenge. And yet for other families, it's a wow, that's terrible. We must all get help in. You see some families with very little support really turn things around for the whole family. So much so when you next see them in clinic, dad has lost 5 kilos. His diabetes is under control. They're all healthy and they've really pulled things together as a family. And each of these families need very different levels of support. They need different support. And it really is about personalizing the input that we give for these families. And lastly, is often families are really relieved not to have type 1 diabetes. And I often ask them, would you rather have type 1 or type 2 diabetes? And they say, oh God, thank God we've got type 2 diabetes rather than type 1. But prognostically, actually, they'd probably be better off having type 1 diabetes. From what we're seeing is those young people with type 2 are likely to have lots and lots of comorbidities and are likely to have a much more significantly shorter lifespan with more complications than those teenagers who are diagnosed with type 1. So we really need to get it into the families. We see that type 2 diabetes is a really significant illness to get. Although they might not feel particularly unwell now, it has a potential for massively impacting on their quality of life in the future and also the length of their life. So after seeing the first patient went quite smoothly. Mum was there, on the ward. It was fairly smooth. Mum was really shocked. She thought, well, we really need to pull things together, and we started on metformin and some insulin with the hope of weaning insulin, and off they went. And when I reviewed them, a month later, her HbA1c had gone from 8.9 to 6.9 in the case of a month. They'd really pulled together. They'd changed their lifestyles. Mum was being really healthy, and I asked AD, how's it been? I saw her alone. I said to her, how's it with Mum seems to be kind of quite full on. She's put in a lot of changes. Are you okay with this? Is this stressful? What's going on? And she said, actually, you know what? It's been really helpful. I was quite stressed before about eating, but the new sort of structure in our house, we've all become healthy together, has made life a lot easier. I'm now less stressed about food, and I'm now feeling much better. But in contrast, the second patient, when I went up to see her on the ward, I'd been warned that she'd been recently admitted to a sister hospital with overdoses. And I thought, oh gosh, I think there's probably going to be quite a lot going on here. So I said, right, let's go down to outpatients, because I don't know about you guys, but trying to get a decent history from someone on the ward can be practically impossible. All our side rooms were busy. There were lots of different meetings going on. So I said, let's go down to outpatients and let's have a catch up. Mum wasn't on the ward. She said Mum's on her way. Despite having a 12-minute tube ride to UCLH and a 5-minute walk from her house to the tube, there was no sign of Mum, and still no sign of Mum. So I said, right, let's go down to outpatients and see and have a proper catch up. Because clearly there was a lot going on in this young person's life, and I needed to get a proper assessment of what was going on. Because I think from the start, if it's really important to know the young person as a whole. And when I say, I'll say to them, look, I really want to get to know you, because diabetes is just a small part of your life. I'm your doctor. I need to work out how to help you. And the way I can help you most is if I understand more about you, what you like to do, what your challenges, what you're good at, what you want to do in the future. And then I can give you the best advice if I get to know you as a person. And importantly, I can help you more if you're honest with me, because if you share your difficulties, then I can come up with some answers and suggestions for you. And I'm not here to blame you. I'm here to support you and come up with the best ideas. And we can share these ideas. And if they're good ideas for you, great. And if they're not good ideas for you, then tell me, and we'll try to come up with some better ideas between us. And confidentiality is hugely important. I think it's something that it's very easy that we forget to remind patients of what confidentiality means. And I was quite lucky because Mum was late. I was incredibly frustrated that Mum was so late at the time, but in hindsight, it was very useful that Mum was late, because we managed to have a good hour together, catching up and trying to work out what was going on in her life. And just a quick reminder, what does confidentiality mean? So I know it's probably slightly obvious, but I'd argue it's not that obvious. Lots of people don't know what the word confidentiality means. And I think it's really important that we say to them, look, this confidentially means this is private between you and the team. It's not you and me, it's between you and the whole team, because we're a whole team, we need to work together. What is it that stays confidential? Remember that particularly young adolescents, they're quite concrete, dangerous. They know that smoking is dangerous. They've been told that smoking is dangerous. If they tell us, that means it's dangerous. Therefore, we have to share things with other people because they are doing dangerous things. So I think it's important that we tell people what needs to stay confidential and what doesn't. So if it's normal teenage stuff, and then I choose age appropriate things for them. So for the 14-year-old, I might say if it's trying alcohol, If it's the 15-year-old, I might say having sex with someone of your own age with consent. Then it's okay that we keep it private. And again, if it's normal teenage stuff, and I might bring in smoking, might bring out trying different levels of alcohol. However, if I say to them, if someone tells me that's really serious, and when I mean really serious, that they want to kill themselves or they're being abused, then I will share it. And I think it's important to differentiate, because then they start to realize what they can share more openly. Because I think lots of young people are really scared of sharing things with their doctors because they're not sure what they're allowed to share. And I think it gives them permission to share more. But then it gives them permission to share more. People are often concerned when I teach them this, that they go, well, hold on, they're not going to tell you the safeguarding stuff, the important stuff. And my response to that is, young people have an opportunity every day of the week to share the real safeguarding. If they're being abused, if they're really, they're suicidal, they've got opportunities to share it every day. They could tell the teacher, they could see a policeman on the street and tell them, they could phone Childline, they could call 999. They have opportunities every day, but on the whole, they don't do that. And the reason they don't do that is because on the whole, they can't do it. And when they do share this serious information, they share it to people who they think are going to be helpful to them. And what hopefully we're going to set ourselves up for is someone who the young person feels is helpful to them, is supportive for them, and if they are, and that you're going to be the person who's going to share, to be able to helpfully manage these big disclosures, and it's going to be you that they share it with, because most of the time they're not going to share it with anybody. And if they do share it with you, we'll say, well, if you do say something serious, we're going to get the right help for you. And importantly, we don't need to share it with the parents if that's going to cause problems, because fundamentally, we're not legally obliged to share it with parents. We'd be more legally obliged to share it with social care or to police, but less so with parents. And lastly, when I finish seeing off patients alone, I say to them, look, how much of this do your parents know? Because often you hear a lot of things like, oh God, this is going to get complicated. And most of the time they say, actually, my parents know everything. And you kind of go, phew. But some of the times they tell you some really private stuff that they want their parents to know about, but they just don't know how to tell the parents. And so I say, look, if there's any stuff that you want, is there something that you want me to tell your parents? Because often they do want someone to share their private stuff to the parents and to try to find solutions for it. So we went through a heads assessment, and for those of you who haven't come across it, it's a way of doing a psychosocial history. And remember, it's not just about their strengths, it's not just about their problems, it's about finding their strengths and solutions. She lives with mum, mum's on prolonged furlough, sister's not at home because there was a history of domestic violence between the sister and her, and sister was made to leave home. She's at college, she's behind, she's really stressed, but she does have really good hopes for the future. She wants to study psychology or criminology, which is what lots of people want to study at the moment. She eats when she's bored and stressed. Deliveroo hasn't been helpful to her in lockdown. She's ordering these high-calorie, very sweet puddings from Deliveroo. She finds it hard to leave home, but she does like the gym, and particularly CrossFit, but she does find it hard to leave home. Drugs have recently replaced food. She had unprotected sex 2 days ago. People have talked about the morning after pill. She's not sure about it. She doesn't think she wants it. even though she regrets having it, and the guy she had sex with isn't really the guy she would ultimately choose to be the father of her child. And she's had multiple admissions recently with overdoses. She's not engaging with CAMS, and mum has depression. Okay, so there's clearly a lot going on here, isn't there? And I'm not expecting everybody to be able to know how to start with these things. And clearly, I'm not going to be doing all of this by myself. But it's about having the right team around us to be able to support these things, so that we can hopefully support the important things in her life. And in the process, we're supporting diabetes, because if she's able to get healthy, if she's able to improve her mood, if she's able to get out of the house and be active and change her diet, ultimately, that's what's going to most help diabetes. And along the way, hopefully she'll take some medications as well if lifestyle and activity, if her lifestyle change isn't enough. And it's often really hard talking to people about food and body weight. And the EDEQ I find is particularly helpful. And I'll share these slides at the end, and you can copy and paste that link at the top. This is the EDEQ. It's a questionnaire, but I like this at the online version. And it asks some really good questions to help unpick what the challenge with eating and body shape for this young person is. And at the end, you get a copy of the score and the globals, and it's broken down either by their global score. Are they restricting the eating a lot? Some people restrict a lot, some don't. And then tells you is there concern about their eating, the weight, and the body shape. And these are particularly useful if you're trying to get an input from CAMS. Sharing a questionnaire that properly scores them and breaks down a score. It's often hard for CAMS to refuse a referral if there's a really objective measure of their distress. Whether or not CAMS have eating disorders services is a whole separate question, particularly eating disorders for those who have excess weight. That's a whole separate question, but at least it gets them through the front door, and it gets them an assessment. And what they might find is that they're depressed or they've got significant anxiety, and working on those can also improve their eating and a few other things to think about with obesity and type 2 diabetes. Activity of these are things that we can do pretty easily. So activities of daily living. She had a broken bed. That's relatively easy to sort out. This is just a simple referral to community occupational therapists. They go in, they do the house assessment, they look at the bed, toileting, showers, and seats. And I've actually rarely had a problem getting somebody to go in and replace beds with hospital bariatric beds, chairs, change baths to showers. It's relatively easy to sort out, and can make a significant impact on families. Aches and pains. Often people aren't referred to physio because they're told, go away, just lose weight and you'll get better. But I think we all know that losing weight is really challenging. So thinking about any MSK difficulties and then referring them to physio for support. She was bedwetting and polydipsia. Lots of kids have concurrent sleep apnea. It often gets better with a broken bed or sorting out their hay fever. But if it doesn't, then getting a proper sleep assessment and then thinking about support for sleep apnea if possible. At this time of year in particular, lots have blocked nose and allergic rhinitis. They're not using their nasal sprays correctly. They've got one hasn't got a good demystifier, a good mister. So teaching them how to use their nasal spray. She was also missing college for heavy periods. So again, thinking about what we do we get prescribed some tranexamic acid? Do we put her on the pill to help her stop missing college? Because then she's stressed because of college, and that missing college, so that adds additional stress. Health prevention industry, she didn't want the COVID vaccine. She was worried about risk and other things such as headaches. So we then think about which medicine is best for you. And I use medicine in quotations, because probably the best medicine that we can offer for type 2 diabetes is getting active, changing dietary habits. And then clearly there's also medications, because we know that exercise and dietary change often isn't enough, and that we need medications as well. And some families do really well with just some advice. And so, for example, the first patient we talked about today, they needed some simple advice, and probably they actually didn't need much advice at all because they knew what it was to do a healthy lifestyle and they just go off and do it. And some families, advice isn't enough and they really need help in doing it rather than just being told, advise what to do. This is Bevan. She's a fellow at the UCL Institute of Exercise, and she's been doing some work with us. She met one of our patients. She's Salma. And when she took an assessment, she went to do an assessment because we were talking about how to do a formal exercise assessment on our young people with type 2 diabetes. She left the consultation and came to me, and she had this shock on her face. She's been used to seeing Olympic athletes, and she was like, Billy, I cannot believe how little movement Salma does. I mean, literally, she doesn't move. She goes from her desk doing her revision. She walks out of the house to the bus station, which is literally outside her house. She gets the bus to college. She sits at college. She gets the bus back. At weekends, she has a job, but that is sitting down, teaching other people, and then she goes home. And she reminded me that the biggest way we can improve people's health isn't getting the active people to be more active. The biggest improvement we can get is inactive people such as Salma to get moving. And Salma's actually done really good progress over the last year. She's been using lots of homeline apps, apps, and trying to help. And she's really sensible. She's been doing lots of research, finding the apps that are entry level for people with excess weight, because a lot of the apps out there just aren't very appropriate if you're overweight. And then the second thing Bevan's gone off and does is that we don't really have a way to measure fitness. And she's gone off and validated the 6-minute walk test, which is done in adults to see how fit they are. It's relatively easy to do. You see how far you can walk in 6 minutes, and that has been shown in adults to be a good measure of how fit somebody is. So and the results will be published soon. So physical activity is really good. It's really important, and we need to get people active. And so we'll hopefully publish some more of work we're doing how to get people active. Lifestyle advice is really difficult. I think dietitians it's really hard to give advice. Marion Devlin, if you ever need a really good speaker on how to support young people with obesity, Marion is amazing. She's really revolutionized how we support young people with dietary change. And people often come back to clinic having lost multiple kilos, and I say, how have you done it? And they all go, Marion. So having a really good dietitian can make a massive difference. And she's really positive and supportive and tries to come up endless ideas and encouragement for families. And for those of you who don't know, the Newcastle diet, which is a low-calorie diet with developed by Mike Lean and Roy Taylor. Lots of adults are doing it, but it's not yet available in young people. It's not been evaluated in young people. And Pooja Sachdev from Nottingham is about to start a pilot. So hopefully we'll know more about what a low-calorie diet and the role in adolescence is. But then for lots of families, that's not enough. They can't, just advice isn't enough, and they say they need help doing. And I don't know what the situation in Wales is, but in the UK we have what's called early help. So they're not social care. They are provided by local councils, and they can provide either family support workers or youth mentors. It's often a bit hit and miss depending on who they get allocated, but they can really support, because these are people who are practical, hands-on, go into the family and help to enable change. There's lots of third sector organisations such as Red Thread, who we use for those with violence. And generally social work is a real last resort because they're often not particularly practical. And again, it's really hit and miss who they accept and who they don't accept, and who they take seriously and who they don't take seriously. The school counsellors, and there's also CAMS to support. Which medicines work? And I've spent relatively little amount of time because I know we largely want to talk about supportive. And remembering that metformin is good enough for some. From the Today study, we saw that metformin, everyone had baseline education. If they got metformin alone, they were able to maintain an HbA1c less than 8% for 2 years. Only half of them were able to do that. So clearly metformin is good for half, but not good enough for the other half. If you added intensive life support over the next 2 years, that didn't make a difference. Of the sort of intensive life support that they were offering, it didn't improve treatment failure, but adding rosiglitazone did help. Rosiglitazone and its sister pioglitazone are slightly more concerning these days due to other side effects. So we know that metformin is good, but not great. Often insulin gets added on, but lots of people don't like it because it makes you put on weight, and weight is a big problem. And more recently, liraglutide has been licensed, and in the 2018 paper by Tamberlane and co found that adding in GLP-1 helped improve HbA1c by 1% at 6 months and 1.3% at 12 months. This is licensed, it's out there, it's available, so do use it because it does help. But metformin is often a hard medicine to use because it's a big tablet, it has lots of GI side effects. So please remember, if you can't swallow it, there are different tablets out there. Some patients get round tablets, and round tablets are often easier. You can crush the slow release tablets, but definitely not the modified release. And I think that helps avoid liquid, because liquid is massively expensive and doesn't taste very nice. I don't think there's real reason if you can crush the slow release. If there's too many tablets, you can get 1,000 milligram strength from the pharmacist. If people get nauseated with it, remind them that you must take it with food. Often they try to take it in the morning, but they don't have breakfast. A way to avoid this is just taking it once a day with dinner. If people forget, again, ditch the twice daily regimen, and you can have 2 grams once a day after dinner. Most people, that's their main meal of the day, and they can have it with dinner. If you don't like the taste, you can crush it into food. And again, what's the maximum? If they can tolerate 500 grams a day, or they can tolerate 1,000 grams a day, but they feel sick with 2,000, then 1,000 is better than nothing as a last resort. So just get to the maximum tolerated dose. And the best medicine is one you can actually take. So you can see here there's lots of different options. Just to remember, this wasn't meant to be a talk on different drugs. But what we can see here is there's lots of different combinations. So licensed is GLP-1 agonist, liraglutide is now licensed. But if they say, look, I don't want an injection, and their mum is using an SGLT2 inhibitor such as dapagliflozin, and they're willing to take the risk, and they're post-pubertal, then I think with some people we've got to prescribe an off-license medicine, because with many families with type 2 diabetes, the medicines literally get passed around the dinner table because everyone is taking theirs. And if mum's on a SGLT2 inhibitor and mum has found it helpful, then that is going to be a good medicine. That's likely to be a good medicine for the young person, and it's fine to prescribe it off license. Because some people want a tablet, but also don't assume that. Some people want an injection. Some people want an everyday medicine, and some people want once a week. So if they're happy with the once a week, then liraglutide is fine. But if they forget and they think, actually, you know what, I'm not going to be able to take it once a day, then think about doing a once a week version, such as semaglutide. If they don't like needles, then think about dulaglutide, because that's got a hidden needle. And lastly, all of the things we talked about often isn't enough. That they can't, even if you do manage to change your lifestyle, but you're not improving your health, then there is a role for bariatric surgery. Because when you combined 2 cohorts, the Today cohort in the US, which was a cohort with type 2 diabetes, and then if you age match them with the Teen Labs cohort, who was a cohort who underwent bariatric surgery, look at the difference between a medical treatment and a surgical treatment to 2 years, the BMI change difference was nearly 30 kilo per meter squared. And if you have bariatric surgery, not only do you lose weight, but diabetes, you need less medications. It helps bariatric surgery. It helps fatty liver disease. It helps sleep apnea. It helps hypertension. And it's not because bariatric surgery makes us change our lifestyles, it changes our physiology. Because if you do bariatric surgery on rodents, and we assume that rodents don't care what they look like in their bikini, it makes them choose healthy. Those who have bariatric surgery choose healthier food when they're given the option of healthy and high fat foods. They choose healthier foods, and they choose to do more, and they do more exercise compared to those who have a sham operation. So bariatric surgery does improve change our physiology, making it easier to get healthy. So to finish off, feel-good story. Ali was an 18-year-old who's got multiple sclerosis. He was really struggling with engagement with our neurologist. And in 3 months' time, we managed to get his HbA1c down from 11.5% to 6.5%. So there is hope for these young people. I think they can make a massive change, but they do need some holistic support, and they often have many complex needs. So in summary, they're hard to treat, they're hard to get engage in research, but it's not impossible. And I think it needs a collaborative approach with good team around you. So I will stop there. Here's my email address, and I'm open to questions.
Thank you so much. That was really, really interesting. Does anybody have any questions for Billy? You've stunned us all into silence. My question was going to be about the prescribing off license. And, you know, we only have small numbers in our individual clinics in Wales, probably. I suspect there's some underreporting going on, and we've started, we've looked at our numbers. And how you feel about people prescribing sort of for small numbers off license, or whether it should be done perhaps centrally.
Yeah, so I think there's a few ways around that. I think any condition where we treat less than five patients, which is what the majority of units in the UK have, less than 5 patients. I think we wouldn't do that for cancer. They would get referred into a specialist centre, and I don't think we should be doing that for type 2 diabetes either, if we can't get diabetes under control with the first-line medications. So I think if we're not able to get diabetes under control with first-line medications, we should either be recruiting our adult colleagues in our local hospital who can prescribe with us, or be prescribing or getting support from a specialist centre who sees lots of patients who can then advise on that. I don't think referring outright to specialist centres work, because the holistic care often works best locally if you're able to do that, but getting support from a specialist centre with prescribing off-licence drugs can help.
Thank you. Chris Bidder, you had your hand up.
I had the same question.
Okay.
Exactly that I've got 2 patients in my clinic, so I think I'm never going to build up knowledge and expertise about complex medicines. The other question I had is, currently in Wales, there are no circumstances at all when it's possible to get bariatric surgery for anyone under the age of 18. Does anyone know, it's a question for Billy really, or is there any way we can access it from outside Wales?
Well, I can answer that as well. Is that in England, it's not much better. There's no nationally tendered services, but NHS England are about to tender for between 2 and 4 national centres. There'll be likely to be one in the north, one in the south as a minimum. And I'm assuming that there could be arrangements to refer into England from Wales.
I'll just read the 2 comments and then come back to you, Becky. So Rian is saying, how do we tackle the issue of obesity before it gets to this point? And Will Williams is asking, do you in UCLH have very low carbohydrate diets or low carbohydrate diet programs for your adolescents?
Okay, so how to tackle obesity, that's the $1 million question. Primarily, it's not for us clinicians, it's a public health problem. When you have 20, 30, even 40% of some populations with overweight and obesity, then it's a public health problem. We, as individual clinicians, I don't think can fix this.
Oh, sorry, it's low calorie diet, not low carb diet.
And then the next one, so low calorie. We're not doing any low calorie diets at the moment, but we're planning to be a pilot site for Pooja's low calorie study, which will follow in the similar veins as the adult Newcastle diet.
So watch this space.
Yeah.
Becky?
Yeah, thanks for that, Billy. Sorry, I didn't hear it all the way through because I've just been fending off stuff here, but I was just going to pick up in terms of Chris's question and obesity services in Wales, in terms of certainly when I was in Gwent, we were liaising with the Bristol team with some of our patients, and again, they are very keen to look into that. So I can share his details if anybody wants those. But I guess within Wales, we do need to think about how we look at developing this service in terms of bariatric services and obesity services as a joined up way. And again, I've sort of moved post, so I'm not so involved in that. But I think maybe in terms of our type 2 patients, there is work to be done to sort of bring all of that together as well. So maybe we do need a type 2 working group within our network, possibly, and we need to sort of take that forwards.
But Becky, I think we absolutely do, and perhaps we can recruit you.
Yeah.
Don't answer now.
No, I've got some thoughts, so maybe that's sort of for further discussions.
Yeah, I mean, for context, for the UK, we've been talking about for years, and NHS England have finally come up with some money for regional obesity centres. They're going to have 2 per NHS region, so that'd be 2 for the whole of London. And where each service each going to get 350 grand. So it's not a huge amount of money, and clearly we're not going to be able to fix obesity for half of London for 350 grand. But it's starting, and hopefully the services will be able to deliver some more work similar to what I've been trying to do at UCLH. But there is very little money around. You know, for these complex young people who come to see me with type 2 diabetes, I'm not getting paid any more than any other service is getting for their patients with type 1. Yet clearly they're more complex and they require a lot of work.
Thank you. There's just a couple of comments about a service that is starting up or is up and running in North Wales that's for obesity, and it's identifying type 2 patients. And certainly when Becky was working with us in Gwent, she was also having the same experience, that she was seeing the children for obesity but identifying type 2 patients. So I'm sure that they are just out there and we just haven't seen them yet. Well, thank you so much.
I didn't mention it, but a reminder that actually do an HbA1c when you can, because it's a really quick and easy test. They don't need to be fasted, and I think that's a message to get out to our teams back in our home hospitals. That people, you know, particularly inpatients, they will often do bloods. They will see that the patient is overweight. They will see that the patient, you know, is coming from a risk ethnicity, and it's incredibly easy and relatively cheap to add on an HbA1c. And I suspect we'll pick up a lot more with type 2 if we just do that.
Thank you. We really appreciate you giving up your time to come and talk to us. It's been a really, really interesting and I think thought-provoking talk for us in terms of organising our services in Wales. So on behalf of the network, thank you very much, Billy.
My pleasure. Thanks for inviting me.
Thank you.
Bye.